Thank you, everyone. So usually all the boring topics are kept towards the end. So right now, because it's a surgeon's discussion, so a small disclaimer is that nowadays we are not really doing more of adjuvant therapy in esophageal cancer. We are going more towards the neo-adjuvant setting. So, but still, what to do if in case we get a patient who has undergone upfront surgery? So this is what I'll just be discussing in the next couple of minutes. So this is a brief introduction I think you must have been hearing. But unlike for surgeons, for us, esophageal cancer is divided into two types. We have a squamous cell cancer and we have an adenocancer. For surgeons, I understand it's only cutting, but for us, it's a two different entity because we treat them separately. We treat squamous cell cancer with a separate approach and adenocarcinoma with a separate approach. So what is the actual way, proper way forward? So unlike in other malignancies, we do not have an Indian-specific guidelines. So this is what we generally follow. For squamous cell cancer, we go for an approach of neo-adjuvant-based chemoradiation, then see if the patient can undergo surgery. And following surgery, if in case there is some sort of residual disease, we go for adjuvant immunotherapy. But whereas for esophageal adenocancers, it's predominantly perioperative kind of approach. You give them initially some chemotherapy, go for surgery, and give again chemotherapy. So it's a perioperative chemotherapy kind of approach. Japanese, they are very simple. So they divide patients who can tolerate into surgery. For people who can tolerate surgery, they give them neoadjuvant treatment, then take them for surgery. Who cannot tolerate surgery, they go for chemoradiation approach. So never surgery alone in esophageal cancers because for locally advanced disease, despite best surgeries, margins are often positive to tune of 40 to 50%. And surgery alone, the outcomes are inferior. You have a 5-year survival less than 20%. So that's why we follow a multimodality based approach. So surgeons, the oncologists, the radiation oncologists, the dietitians, they all sit together. They can improve the outcomes of these patients. So again, though my topic is supposed to be on adjuvant treatment, I would advocate for neo-adjuvant kind of therapy in esophageal cancers because this is one randomized trial which has actually proven that neo-adjuvant based approach improves the survival in esophageal cancers. So these are some of the theories why you go for neo-adjuvant because you have a intact vasculature, you can accurately design the radiation field, there is a better patient tolerance, tumor downstaging is achieved, and you can also know whether the tumor is actually biologically aggressive. With this, we enter into the actual topic. So this was one survey which was conducted during my residency back at All India Institute, Delhi. So this was a aggregate opinion of around 40 doctors from different parts of the country, and they answered around 30 questions, practical questions as to what to do with a patient of esophageal cancer, of which I have taken some questions which are relevant to us in adjuvant setting. So now we have a patient on Monday morning who is operated for thoracic esophageal squamous cell cancer. All nodes are negative, all margins are negative. The surgeon has excellently dissected. So this was the consensus that was obtained. Majority of the patients actually opted for adjuvant chemoradiation. Shall we see whether it's actually correct? So this is the NCCN guideline. So if surgery has been adequate, US people do not recommend any adjuvant treatments. So it's only observation if you have undergone an R0 resection. But for R1 and R2 resection, suppose you have not given any preoperative chemoradiation, then go for chemoradiation therapy. So important to understand is that if the surgery has been adequate, no need of any adjuvant therapy. So this is a meta-analysis. What is the data behind it? This is a meta-analysis of around 5 trials, and where they have found that in completely resected esophageal cancer, there is no advantage of giving any extra additional therapy. Like for example, in this, they have studied surgery versus post-operative radiation. They did not find any increased risk of mortality. So now when do we actually give post-operative radiation therapy? So if the margins are positive, as I have displayed in the prior slide, and if you feel that the disease is very bulky, it's a N3 disease, it's almost a T4 infiltrating the surrounding fat planes. So these are certain indications where you might give adjuvant radiation. So again, adjuvant radiation with or without concurrent chemotherapy. Now, we do not have any randomized data to prove that adding chemotherapy will actually benefit it, but in practice, most of the times we add some chemotherapy if the patient has not received any prior chemotherapy. So again, adjuvant chemotherapy versus observation if the patient has undergone a complete surgery. The only answer is that this is a Japanese trial where they have compared localized squamous cell cancers of thoracic esophagus. Patients have undergone surgery or surgery versus surgery plus chemotherapy. Though there was a disease-free survival, finally they found out that the disease-free survival was actually in this particular subset where nodes were positive. But overall survival was not significant. So if a patient has undergone surgery, finally what we have to understand is that no additional radiation, no additional chemotherapy. Only indication where we might add chemoradiation is if the margins are positive.